Hello everyone, can you hear me okay? Everyone in the back? All right, we're gonna go ahead and get started. Sorry for the technological difficulties. My name is Julianne Fallon, and today we're gonna talk about atherosclerosis, and we're gonna pay particular attention to the kind of growing attention that's coming on the role of inflammation in this disease state. I have nothing to disclose. So what are we gonna talk about today? We're gonna review the pathogenesis of atherosclerosis, identify potential drug targets that slow the progression of atherosclerosis, and then compare current methods of prevention as well as emerging treatment options for atherosclerotic cardiovascular disease. So what is atherosclerosis? Typically when we encounter this clinically, it's something we call ASCVD, or atherosclerotic cardiovascular disease. And this is made up of coronary heart disease, so your patients who have had an acute MI or an acute coronary syndrome, either unstable or stable angina, as well as stroke or transient ischemic attack or peripheral artery disease. And of course, why are we talking about this? Cardiovascular disease is a leading cause of death in the United States, with over 600,000 deaths reported in 2015. So before we jump into pathophysiology, I want to take us on kind of a journey through time of where atherosclerosis research has kind of been. So as early as even the 1700s, a man named Albert von Haller described something he referred to as an atheroma, coming from the Greek word for porridge. And this described the degenerative process observed in the intima arteries. He was followed by Antonio Scarpa, who was the first to present an anatomical description of arterial wall degradation in full detail, and I've included one of these pictures here, and you can see it's pretty much exact anatomic replica of the heart. He also suggested an underlying metabolic disorder. He was followed by Joseph Hodson, who in his treatise on the disease of arteries and veins described inflammation as the underlying cause of atheromatous arteries. So I want to take a moment to point out that this idea of metabolic disturbances and inflammation aren't new concepts. These are things we've been thinking about since the 17 and 1800s. John Loewenstein went on to describe the further process of this atheroma to arteriosclerosis. So similar, arterial meaning gruel or porridge, and sclerosis, hardening of the veins, and referred to this as sort of that progressive degenerative process of intimal proliferation of connective tissue and calcification. In 1856, Rudolf Virchow, who we know quite well for his works explaining thrombosis, but he also described the atheromatous process in arteries, suggesting that the first development of atherosclerosis was injury to the intimal lining of the arteries, and he also emphasized the inflammatory ulcerative nature of atherosclerosis. So again, going back to these ideas that aren't new concepts in our current day and age, we've been thinking about them since even the 1800s. Felix Marquand, of course, I want to mention because he coined this term atherosclerosis. Again, athero from the Greek word for gruel or porridge, and sclerosis for hardening. And again, further describing this degenerative process of the intimal layer of the arteries. Now, a landmark thing happened in 1913 with the work by Nikolaj Anichikov. He was actually able to induce atherosclerosis in rabbits by feeding them a diet of pure cholesterol. This proved kind of this cholesterol theory of atherosclerosis. Mark Rufer I wanted to include in here because he did this work looking at the arteries of Egyptian mummies. So even these mummies from over 3,000 years ago have the same degenerative changes of the arteries that we would see today. And then Russell Ross, in the 70s, proposed something called the response to injury hypothesis. And this was a very popular hypothesis that stated that essentially an injury occurred to the endothelium of the arteries, and this caused the arteries to respond. So a series of events occurred leading to smooth muscle cell proliferation, and that was what caused the narrowing of the arteries. He revisited this theory later in the 1980s, where he still stood by this idea that an initial injury is what causes this process to start, but moved a little bit away from smooth muscle cell proliferation being the primary cause of the narrowing of the arteries. Another large milestone was made in the 1970s by Michael Brown and Joseph Goldstein, when attempting to understand the pathophysiology behind familial hypercholesterolemia, discovered and characterized the LDL receptor. So the LDL receptor works. Typically it's expressed in the liver and hepatocytes. It finds LDL that's circulating in the plasma, takes it in to the cell, where it then degrades it. This results in some regulatory actions. So a decrease in HMG-CoA reductase, which, as we might remember, is the rate-limiting step of cholesterol synthesis. It increases the formation of cholesterol oleate, so again, breaking down that cholesterol, and it actually works to decrease the expression of LDL receptors. So in a normal cell, we see that process I just described, where the LDL pool is able to sort of balance itself. In familial hypercholesterolemia, those LDL receptors are inherently defective, which leads to large pools of LDL since you have no way to clear them from the circulation. And in patients with a high-fat diet, you see that the receptors become saturated and the receptors themselves become downregulated, leading to these large pools of LDL. So touching quickly on the landmark discovery in the 80s, as these sort of build on what we are currently believing as the process of atherosclerosis in current times. We have the work by Daniel Steinberg, who described the central role of oxidized LDL in atherosclerosis and the role of the scavenger receptors in mediating LDL uptake by macrophages. We also had Goran Hansen, who really described the cytokine expressed in the atherosclerotic plaque, and Russell Ross when he revisited his response to injury hypothesis. So a simplistic view of why atherosclerosis occurs is that atherosclerosis results in plaque formation. Over time, the plaque formation causes narrowing of the arteries, and narrowing results in decreased oxygen circulation. The plaque may go on to rupture, leading to an infarct, and that infarct can result in stroke, heart attack, or death. But again, that's a very simple way of describing it. Things are a little bit more complex. There are a lot of different elements involved and a lot of cytokines, but we'll focus on the most important ones today. So the first thing that happens is endothelial dysfunction. So an injury occurs to the endothelium, which causes changes in that kind of normal homeostasis. This leads to the ability of leukocytes circulating in the plasma to adhere to the endothelium and migrate into the intima. Over time, we see something called the fatty streak develop. The fatty streak is one of the first visible signs of atherosclerosis and the first lesion you're really able to see. This is primarily made up of foam cells, and their formation is mediated by oxidized LDL and interleukin-1, as well as tumor necrosis factor alpha. It's also mediated by T cell activation caused by the actions of interleukin-2 and tumor necrosis factor alpha as well. You also see some smooth cell migration, smooth muscle migration. So how do these foam cells form? First, you have your circulating monocytes in the blood. They adhere to the epithelium, where they then migrate into the intima. Once in the intima, they differentiate into intimal macrophages, and these macrophages present scavenger receptors that are able to pick up these modified lipoprotein particles, so your oxidized LDL. They then, once this LDL goes into the cells, they form these lipid droplets, and that macrophage is really considered a foam cell. The macrophage continues to do its job, kind of breaking down cells, and some of these macrophages are dying. It's also releasing cytokines and inflammatory mediators. These cause more monocytes to migrate to the endothelium and become macrophages that go on to become foam cells. You also have localized proliferation of these macrophages. So going back to Daniel Steinberg from the 80s, he described the oxidatively modified LDL and noted that it was slightly structurally different, and this really allowed it to have an increased rate of uptake and degradation through the acetyl LDL or scavenger receptor, leading to this foam cell formation. Over time, we have accumulation of these macrophages and the formation of the necrotic core from those dying cells. And all of those cells in this continued inflammatory response are covered by a thin fibrous cap. Over time, you have the lesion growing larger, this cap protruding into the artery, and you have restructuring of the lesion as well as dilation of the artery to accommodate this increased mass. Over time, all those inflammatory cells that have made up that lesion start producing proteolytic enzymes. These enzymes can cause thinning of the fibrous cap, leading to the potential for thrombus. So the fibrous cap breaks open, leading to acute phase reaction full of the platelet response, leading to all of those acute infarcts. So this leads us to our assessment question 1. Which of the following goes on to become a foam cell? Is it A, monocytes, B, lymphocytes, C, cytokines, or D, smooth muscle cells? All right, the A's have it, monocytes, exactly. So these are the cells that kind of, once they reach the endothelium, become macrophages, which pick up LDL and go on to become foam cells. So next I'm going to talk about the major ASCVD risk factors. So the 2014 National Lipid Association guidelines recommended 5 risk factors as being the major ones that cause the formation of atherosclerosis. Smoking and hypertension lead to the formation of reactive oxygen species, which can cause that initial endothelium injury. Family history of early coronary heart disease indicates that there may be a genetic component. This is especially true when you think of patients who have familial hypercholesterolemia, who have these elevated levels of LDL, which can then, of course, become those foam cells. Age makes sense because we know that atherosclerosis has a very long, early silent phase. So even now, a lot of us are probably forming lesions, but they're probably not to the point where they may burst and cause problems. But your risk accumulates over time. And then low HDL. So low HDL is part of the metabolic syndrome, so as well as like high blood pressure and increased triglycerides. And increased HDL is actually a negative predictive risk factor. So with each 1 milligram per deciliter increase in HDL, you can see a decrease in coronary artery disease by 2 to 3%. So looking at the American Association of Clinical Endocrinologists and American College of Endocrinology guidelines for the management of dyslipidemia and prevention of cardiovascular disease, you can see that their major risk factors correspond quite nicely to the National Lipid Association guidelines. The only thing they add are things like that respond to the cholesterol panel. So increasing cholesterol, non-HDL, and LDL. They also add diabetes and chronic kidney disease as risk factors. They also include 2 non-traditional risk factors that I want to briefly talk about. One of these is lipoprotein A2, which is a marker of inflammation, and then the one that we see most often in clinical trials, which is high-sensitivity C-reactive protein. So high-sensitivity C-reactive protein is a marker of systemic inflammation. It's an acute phase reactant that's produced by the liver, and it's just as important as LDL in predicting cardiovascular risk. A normal level of high-sensitivity C-reactive protein is less than 1, and patients with a level of 1 to 3 have intermediate cardiovascular risk, and greater than 3 have high cardiovascular risk. The use of the high-sensitivity C-reactive protein has been validated in many studies, and you can see a clear correlation between increasing C-reactive protein and increasing cardiovascular risk. This brings us to a patient case who I want to introduce now and who we will follow through the rest of the presentation. So we have John Smith, a 6-year-old male presenting to the UVA health system for a routine yearly checkup. He's a current smoker with a 1-pack per day, 40-pack year history, and his father died of an acute MI at age 50. His past medical history is significant for diabetes with an uncontrolled A1C, hypertension, COPD, and a STEMI last year. He's currently on lisinopril, simvastatin, metformin, though it's unclear how often he takes it, and Spiriva. His vitals show an elevated blood pressure and a heart rate of 80 beats per minute. You'll notice his cholesterol panel is somewhat elevated with a total cholesterol of 240 and an LDL of 180. His HDL is low at 30, and his high-sensitivity C-reactive protein is 3. So the first thing we want to think of when we're looking at patients with these risk factors is prevention and treatment targets. So the best thing we can do for our patients is lifestyle changes, so really encouraging smoking cessation, weight loss, a heart-healthy diet, and exercise. The next important thing is for management of our patients' chronic disease states, such as hypertension, diabetes, and particularly hyperlipidemia. And there may also be a role for inflammatory pathways. So first we're going to talk about cholesterol. So when we talk about cholesterol, our targets are going to be apolipoprotein B containing lipoproteins. So that's your LDL, your chylomicrons, and your VLDL. Apolipoprotein B is the primary protein constituent of all atherogenic lipoproteins, and those atherogenic lipoproteins are the primary identified cause of atherosclerosis. ApoB provides a structural integrity to the particle and also acts as a ligand for receptor-mediated clearance. Plasma LDL is going to be our largest target since it's the most widely circulating atherogenic lipoprotein. It's able to penetrate the arterial endothelial cell lining and enter the subendothelial space, where it can then be picked up by those macrophages and become a foam cell, part of the foam cells. So the first major drug class we're going to talk about are statins. As you may have guessed, these are FDA approved for dyslipidemia, including familial hypercholesterolemia, and as well as for the prevention of cardiovascular disease. They work by inhibiting HMG-CoA reductase, so they competitively inhibit the rate-limiting step of cholesterol synthesis, and they also upregulate hepatic production of LDL receptors. So not only is less cholesterol being formed, but there's also more LDL receptors to pick up this LDL from circulation. And LDL lowering is dependent on the statin and dose. Here I've included our much beloved statin intensity chart. Most patients that we have will be on high-intensity statin therapy or moderate-intensity statin therapy. High-intensity statin therapy is a daily dose that lowers the LDL by approximately 50%, whereas moderate intensity can lower the LDL by approximately 30 to 50%. When we look at groups that have been shown to have benefit with statins, there are 4 very clearly emerge. One of these is the group with clinical ASCVD, and that's the group that we will focus on today. And they should be having a high-intensity statin unless they're older than 75 or have other tolerability concerns, in which case you can consider a moderate-intensity statin. The other 3 groups involve different combinations of LDL, age, or disease stage such as diabetes, or 10-year ASCVD risk. Across the board, patients are recommended to have either a high-intensity or moderate-intensity statin, and there appears to be very few rules for the low-intensity statin group. Now, when we talk about statins and benefit, there are tons and tons of trials. I could probably spend the next 2 weeks talking to you about each of these trials, but I won't do that to you today. Today, we're just going to focus on 2 of these. One, a primary prevention trial called Jupiter, and a secondary prevention trial called Prove It. But before we talk about those, we'll go back to our patient case. So John Smith has returned after 3 months. He was really worried about all his cardiovascular risk factors. He's decided he's going to try to stop smoking. He's really been trying to eat better. He started taking his metformin more regularly, and his A1C's come down a little bit. We see with his diet changes and more regular taking of his medications, his blood pressure has come down a little bit, still elevated at 140 over 88. His cholesterol's come down some, though his total cholesterol is still 200 and his LDL is 140. His high sensitivity C-reactive protein has not changed. This takes us to our second assessment question. After adhering to a heart-healthy diet and exercise plan, John's lipid profile is approved to total cholesterol of 200, LDL of 140, triglycerides of 100, and HDL of 40. John's physician wants to switch him to an appropriate statin based on his many cardiovascular risk factors. So which of the following options is most appropriate for John? Is it A, simvastatin, 40 milligrams, B, pravastatin, 80 milligrams, C, atorvastatin, 20 milligrams, or D, atorvastatin, 40 milligrams? Do I hear D? All right, great job, guys. So, of course, he has clinical ASCVD because he experienced a STEMI last year, as well as, the additional risk factors from family history, etc. So, high-intensity statin is definitely appropriate for him. So now we'll talk about the Jupiter trial, which was a primary prevention trial that compared rosuvastatin 20 milligrams daily versus placebo. It enrolled over 17,000 healthy patients, again, primary prevention, who had an LDL that was less than 130 and a high sensitivity C-reactive protein that was greater than 2. So the reason they chose those particular targets was another study called the Air Force Texas Coronary Atherosclerosis Prevention Study, which showed that patients who had neither elevated LDL or elevated high sensitivity C-reactive protein, so both of those were normal, had a lower risk of cardiovascular events. So this trial is really looking at patients with sort of low normal LDL but an elevated inflammatory risk. Do we see any benefits with statins when we use this treatment? The primary endpoint was the composite of myocardial infarction, stroke, arterial revascularization, hospitalization for unstable angina, or death from cardiovascular causes. We'll see this primary endpoint throughout the trials, and you can think of them as major adverse coronary events. So first, were we able to lower LDL with the rosuvastatin group? We were. LDL was, high sensitivity C-reactive protein was lowered. consistently at 12 months compared to placebo, and this was consistent across time. They also showed that it was able to lower LDL compared to placebo. This lowering was consistent over time. The question still remains. We know we can lower high-sensitivity C-reactive protein and LDL with the statin therapy, but does this translate into a reduction in cardiovascular events? The answer was yes, it does. Across the board, as you look at the primary endpoint and all the components of the primary endpoint, you see that they're all statistically significant. The only endpoint that is not is the hospitalization for unstable angina. And this overwhelming benefit is why this trial was stopped after 2 years. In terms of adverse effects, we see the typical things we would expect from statin therapy. So muscular weakness, stiffness or pain, myopathy, rhabdomyolysis, and some newly diagnosed diabetes. And this really showed us that statins can not only reduce LDL, but they can also reduce markers of inflammation. And this reduction is associated with a decrease in adverse cardiovascular events. Which leads us to the Prove It trial. So this was a secondary prevention trial. So patients were included if they had experienced a recent acute coronary syndrome, and therapy was either atorvastatin 80 milligrams or pravastatin 40 milligrams daily. The LDL target differed just depending on the treatment group, with a more intensive goal for the intensive therapy group, so less than 70 and less than 100 for the standard treatment group. The primary endpoint was very similar to the previous trial, as a composite of death from any cause, myocardial infarction, documented unstable angina requiring hospitalization, revascularization, and stroke. Follow-up for this trial was a mean of 24 months, and this trial saw very similar reductions in LDL, with a median LDL of 62 in the intensive group and 95 in the standard dose group. When we look at the components of the primary endpoint, we can see that benefit emerged for the high-dose atorvastatin group even at 30 days, and over the course of the trial, this benefit became more clear. When we look at other secondary endpoints, you can see that across the board, the risk reduction was more significant with the high-dose atorvastatin group, or at least a trend toward it. Only 2 of these groups were statistically significant, and that was revascularization or unstable angina requiring hospitalization. In those 2 groups, we saw a significant risk reduction compared to, in the atorvastatin group, compared to the pravastatin group. The adverse effects that they saw with the Prove It trial were very similar to what we saw in Jupiter, with an increase in LFTs, so myalgia, muscle aches, or elevations in creatinine kinase. And this trial really showed that, again, lowering lipids reduces cardiovascular risk. But what about C-reactive protein? They actually did a corollary study that was performed by the same group, where they looked at both LDL and C-reactive protein. What they found was that patients who had both an elevated LDL, which they defined as greater than or equal to 70, or an elevated C-reactive protein, so greater than or equal to 2, people who had both of those risk factors had a significantly increased rate of recurrent myocardial infarction or death from any cause, and this was clearly differentiated over time. Another interesting thing that they saw was 2 other groups. So either just elevation in LDL, but a normal C-reactive protein showed more risk, or an elevated LDL in a normal C-reactive protein. So this sort of demonstrated that patients can have 2 types of residual risk, either cholesterol-based or inflammatory-based. And that sort of set people into thinking, what else can we target besides cholesterol? But some of our patients do still have elevated cholesterol, so what can we do for them? The drug class, the PCSK9 inhibitors, came around, and that is the FDA-approved drugs are alirocumab and evolocumab, and they're FDA-approved as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with either familial hypercholesterolemia or who need additional LDL lowering due to clinical ASCVD. So how do the PCSK9 inhibitors work? First, we'll revisit our LDL receptor. So you can see at the label A, LDL circulating gets picked up by the LDL receptor, where it's taken up into the cell, into the endosome, and then degraded. A gene called PCSK9 is also produced inside the cell, where it's expressed and can either act inside the cell or it's released to the cytoplasm where it can interact with the LDL receptor. When PCSK9 binds to the LDL receptor, it triggers it to be taken into the cell, into endosomes, and degraded, which leads to fewer LDL receptors available to pick up LDL in the cell. Where the PCSK9 inhibitors come in, that they're monoclonal antibodies that can bind to PCSK9, meaning that we'll have more LDL receptors and fewer LDL receptors being triggered for destruction. So the question with these PCSK9 inhibitors is whether or not they can lower LDL even on top of standard lipid-lowering therapy. So that's where the Odyssey trial came in. It enrolled over 2,000 patients at high risk for cardiovascular events with an elevated LDL, so greater than or equal to 70, or a maximally tolerated statin dose, so that would be either atorvastatin 20 or 40 milligrams, rosuvastatin 20 or 40 milligrams, atorvastatin 40 or 80 milligrams, or simvastatin 80 milligrams. And these patients could be on or not on additional lipid-lowering therapy. The treatment was alirocumab, 150 milligrams sub-Q every 2 weeks versus standard of care. And this trial really was just looking to see if the LDL could be lowered from baseline to week 24. But they also wanted to look at a post hoc analysis of the major adverse cardiovascular events. The reason they were interested in doing this is because there's another trial going on currently called the Odyssey Outcomes Trial, which will be looking at reductions in cardiovascular events. So the Odyssey trials demonstrated that PCSK9 inhibitors can significantly reduce LDL on top of maximally tolerated statin therapy with and without other lipid-lowering therapy. There was a reduction of about 61% between the standard of care group and the alirocumab group, and this difference was consistent over time, so not just at the 24-week mark, but even out to the 78 weeks of follow-up. So now that we know that the PCSK9 inhibitors can continue to lower LDL, do they have any kind of influence on reduction of cardiovascular events? When we look at the incidence of major adverse cardiovascular events, we see that there was a statistically significant reduction in these events, but when you look at the components of the outcomes, you see that nothing is overwhelmingly statistically significant, which means that we need just a little bit more evidence before we can be comfortable with recommending these for our patients. Looking at adverse effects, we see that there was a pretty good incidence of injection site reactions, myalgias, neurocognitive effects, and ophthalmologic events. And this trial showed that when added to standard lipid-lowering therapy, alirocumab significantly reduces LDL levels and may be associated with a decrease in the rate of cardiovascular events. The next step is the Fourier trial. So this trial studied evolocumab and really looked to see if PCSK9 inhibitors are associated with a decrease in major cardiovascular events. So the patients who were studied were those who had clinical ASCVD and also an LDL greater than or equal to 70, also receiving statin therapy, so receiving that kind of standard of care. And of course, they were looking at the composite of the major adverse cardiovascular events. What they saw was a decrease in these events. And when you look at the components of the primary endpoint, you see that everything was pretty statistically significant with the exception of cardiovascular death. So this trial really proved that continuing to lower LDL in these patients who have that residual cholesterol risk, so LDL greater than or equal to 70, does result in a decrease in cardiovascular events. In terms of adverse effects, we see that evolocumab was associated with similar events to what we saw with alirocumab, so injection site reactions, muscle-related events, and neurocognitive events. And again, proving that PCSK9 inhibitors may be beneficial in some of our patients who need additional LDL lowering. This leads us to assessment question 3. Which of the following medications has been shown to lower LDL and provide the greatest reduction in high-sensitivity C-reactive protein? Is it A, alirocumab, 150 milligrams sub-Q every 2 weeks, evolocumab, rosuvastatin, or pravastatin? Any guesses? All right, guys. The answer is actually rosuvastatin. So the whole time I was talking about PCSK9 inhibitors, I never mentioned anything about C-reactive protein. And in fact, there was a fairly recent meta-analysis in 2016 that looked at kind of all of these PCSK9 trials and reductions in high-sensitivity C-reactive protein, and they didn't see anything significant. So really these drugs are just good for lowering lipids, but really no role in inflammatory pathways. Now when we look at our statins, they have actually been shown, as we saw earlier, in reducing C-reactive protein. And this is thought to be due to these, as they call it, pleiotropic effects, which typically translates into changes in leukocytes and sort of mediating this inflammatory response down the cascade. So going back to our friend John, he is returning 6 months after that initial appointment. He's been switched to his atorvastatin 40 milligrams daily. He's managed to quit smoking, really a model patient here. His A1C is now controlled, nearing that 7% mark. And he's been consistently taking his medications. When we look at his cholesterol panel, he's done it. His LDL is less than 70. The thing that remains is this high sensitivity C-reactive protein. Despite changing his statin dose, despite all these lifestyle changes, for some reason it is still unchanged and still 3. So what options are out there for our friend John, who, now that his cholesterol risk is managed, what do we do about his residual inflammatory risk? Up until recently, this has been an unproven hypothesis. So when we look at potential drug targets for inflammatory, mediating this inflammatory response, our first thought is probably C-reactive protein. We know that this is a great prognostic indicator. We know that lowering it results in a decrease in cardiovascular events. But when we actually try to target it in terms of drugs, we don't see any changes. That leads us to look upstream and higher up. So there's something called the nod-like receptor 3 inflammasome, and this can be activated by a variety of things, including cholesterol crystals, neutrophil extracellular traps, atherosclerotic flow, and hypoxia. When this inflammasome is activated, it causes activation of interleukin-1 beta. Interleukin-1 beta is really reliant on other factors triggering its production and activation compared to interleukin-1 alpha, which is sort of an alarmin that's produced in cells throughout the body, even in healthy individuals, whereas interleukin-1 beta sort of requires this inflammasome response before it's be able to activate. So we're going to talk about interleukin-1 beta and briefly interleukin-6. Both of these are pro-inflammatory molecules that go on to promote all those things we spoke about earlier that increase the risk of atherosclerosis and the formation of these lesions. So they increase vascular inflammation, increase that endothelial dysfunction, increase smooth muscle cell proliferation, cause these macrophages to increase and go to these lesions, and trigger the influence of chemokines and cytokines, which can cause this response to continue to repeat itself. So first we'll talk about canakinumab and colchicine. So canakinumab is FDA approved for periodic fever syndromes and active systemic juvenile idiopathic arthritis. You'll notice that all of these diseases here are inflammatory diseases. And you may have heard of the familial Mediterranean fever, not quite remember what it is, but you may remember that another drug is indicated for this. Its mechanism of action is a recombinant human and anti-human interleukin-1 beta monoclonal antibody. So it's actually able to just neutralize interleukin-1 beta. And it does this very specifically, so it does not interact with interleukin-1 alpha. So when we look at to see how this drug has performed in reducing adverse cardiovascular events, we look to the CANTOS trial. So this trial enrolled over 10,000 patients with a previous MI and an elevated high-sensitivity C-reactive protein, so greater than or equal to 2. They studied 3 different doses of canakinumab, 50 milligrams, 150 milligrams, and 300 milligrams, each that was given subcutaneously every 3 months versus placebo. Their primary endpoint is a little bit different than what we saw in previous trials. So just looking at non-fatal MI, non-fatal stroke, or cardiovascular death. So first, does canakinumab affect lipids? Looking at the trial, we can see that the baseline LDL cholesterol level was pretty much unchanged throughout follow-up, even out to 48 months. Similar results were seen with the HDL and triglycerides. However, when we look at high sensitivity C-reactive protein, we can see that there was a dose-related response in the reduction of high sensitivity C-reactive protein. In the first group, the 50 milligram group, compared to placebo, there was a 26% decrease. In the 150 milligram group, there was a 37% decrease. And in the 300 milligram group, there was a 41% decrease compared to placebo. So our next question is, what were the cardiovascular endpoints with this? We know that it didn't affect lipids, but it did reduce our inflammatory markers. So when we look at the primary endpoint, it was statistically significantly reduced. The p-value they have at the far right describes sort of the average of all the doses of canakinumab compared to placebo, but only the 150 milligram group, when you look at them individually, was statistically significant. Now, when we look at adverse effects, we know this drug is kind of modulating inflammatory pathways, so we need to be a little bit more worried about other things that are going on. Unfortunately, they did see a high percentage of patients in the canakinumab group who experienced fatal infection or sepsis. And this may be due to masking of certain signs of the inflammatory response. These patients may be less likely to have a fever or to have an elevated white count. On the flip side, we actually saw a reduced rate of fatal cancer in the canakinumab group. And this is consistent with other studies looking at the role of interleukin-1 in the progression of lung cancer. When we look at other adverse effects, we see that there were lower rates of other inflammatory disorders, so things like arthritis. These patients in the canakinumab group experienced less of this. On the flip side, they were more likely to experience leukopenia and thrombocytopenia. So overall, this trial was very much a milestone because it was able to prove that lowering just these inflammatory risk factors, outside of lowering cholesterol, does reduce the incidence of major cardiovascular events, and is sort of a pioneer in leading us to consider these other pathways as potential drug targets. There are some downsides to canakinumab, so it's not the magical cure-all for these patients with residual risk due to the fatal infection risk as well as the cost. The injection of the 150 milligram dose is $16,000. So when you add that up by needing it 4 times per year, that gives you $64,000. So not a very cheap option. So what else is out there? We'll talk about colchicine. It's FDA approved for the prophylaxis and treatment of gout, as well as familial Mediterranean fever. You may notice that those things are very similar to what we just saw with canakinumab. And it works, that we believe the mechanism by which it can reduce cardiovascular events is the prevention of the activation of interleukin-1 beta by sort of interfering with the assembly of the inflammasome complex in neutrophils and monocytes. It's also able to kind of inhibit the function of the neutrophils in the circulation. And there's been reports of beneficial effects in cardiovascular disease. So the patients who are being treated with colchicine because they have familial Mediterranean fever and gout were seen to have a lower risk of acute MI. And the trial we're about to discuss, the low-dose colchicine trial, demonstrated that there's a reduction in high-sensitivity C-reactive protein in patients with stable coronary disease. So with the low-dose colchicine trial, this is a much smaller trial than the other trials we discussed. It only enrolled just over 500 patients with stable coronary disease, and they could have been receiving just standard of care, so the regular statin or aspirin. They were treated with either colchicine 0.5 milligrams daily or control. And the primary outcome was the composite incidence of acute coronary syndrome, out-of-hospital cardiac arrest, or non-cardioembolic ischemic stroke. When we look at the primary outcome, we see that it was statistically significantly reduced. This was primarily driven by the reduction in acute coronary syndrome. And of acute coronary syndrome, colchicine was most likely to reduce the incidence of non-stent-related acute coronary syndrome. And of course, adverse effect-wise, colchicine is very well tolerated, with the biggest complaints being intestinal upset, maybe some myalgia or myositis, some rash, alopecia, itch, or peripheral neuritis, but overall very low incidence. So this trial showed us that there are other options out there that can potentially reduce the risk of cardiovascular disease by, again, affecting these inflammatory targets, so like interleukin-1 beta. Next, we'll look at interleukin-6 and low-dose methotrexate. So when we talk about methotrexate, it's FDA approved for neoplastic diseases, psoriasis, rheumatoid arthritis, and it works as a dihydrofolate reductase inhibitor, causing inhibition of purine and pyrimidine synthesis. But what we're more interested in is that it may reduce inflammation by inhibiting the production of atherogenic cytokines, so our interleukin-1 beta, interleukin-1 receptors, interleukin-6, or tumor necrosis factor alpha. It may also induce inflammatory cell apoptosis through the generation of reactive oxygen species. Now, methotrexate is not benign, and it has adverse reactions that are dose and frequency related. And these include ulcerative stomatitis, leukopenia, nausea or abdominal distress, malaise or undue fatigue, chills, fever, or dizziness, and decreased resistance to infection. So not all of these are very benign like we saw with colchicine. Now there have been reports of beneficial effects in cardiovascular disease. There was a meta-analysis by Micah et al. That looked at 10 observational studies in which methotrexate was administered to patients with rheumatoid arthritis, psoriasis, or polyarthritis. It found that patients with rheumatologic diseases on methotrexate had a lower risk of cardiovascular events and a lower risk for MI, particularly, both of these being statistically significant. The conclusion was that direct treatment of inflammation may reduce cardiovascular disease risk. So we tried to test it with a trial. This trial is currently ongoing. It's the Cardiovascular Inflammation Reduction Trial, or CIRT, and they're planning on enrolling over 7,000 patients with a history of either a documented MI or multivessel coronary artery disease. The dose of methotrexate they will be studying is the 15 to 20 milligrams weekly or placebo, and both groups will receive 1 milligram of folic acid 6 days per week. They'll have a 5 to 6 week open label run-in, and eligible participants will be randomly allocated over a 3 to 4 year period to usual care plus placebo or usual care plus low-dose methotrexate. The primary endpoint will be what we saw with the CANTOS trial, so positive non-fatal MI, non-fatal stroke, and cardiovascular death. Time frame of follow-up will be 6 years, and they'll be testing the inflammatory hypothesis. So just like the CANTOS trial, the methotrexate is not believed to reduce cholesterol levels, your LDL, etc. But we know it has an effect on inflammatory molecules. So we will see if this trial echoes the same results we saw with the CANTOS trial. And it's estimated to be completed in December of 2019. So now that we've talked about inflammatory risk, we'll go on to assessment question 4. Which of the following medications has proven to reduce the risk of cardiovascular events independent of lipid-lowering ability? Is it A, atorvastatin, B, colchicine, C, canakinumab at a dose of 200 milligrams sub-Q every 3 months, or D, canakinumab 150 milligrams sub-Q every 3 months? What do you all think? I heard D, which is the correct answer. So exactly, the CANTOS trial was one of those hallmark trials that showed us that lowering inflammatory risk outside of lowering residual cholesterol risk does show a reduction in major adverse cardiovascular events. So to kind of wrap us up today, risk factors for ASCVD have been well described in the literature with renewed focus on inflammatory risk. Reducing LDL plays a significant role in reducing cardiovascular risk, and residual inflammatory risk may be present in some patients, leading to a need for new treatment options that mitigate this risk. The CANTOS trial proved that inflammatory risk reduction improves cardiovascular outcomes, and what I'm excited to see is as we explore more of these inflammatory targets and see if we can continue to lower the incidence of these adverse cardiovascular events, but also employ treatments that can be maybe affordable for our patients, in addition to providing benefit. Here are my references, and what questions do you have? All right, well, that'll wrap us up for today. Thank you all so much for coming.